All right, so we're going to move on to anemia and primary care. This is going to be all one, so take a break if you need to take a break. I'm hoping that this will not last longer than 30 minutes. So I'm going to get started on the slideshow here. First, I'm going to go over a little bit of pathophysiology because if there's one thing I want you to do as a nurse is try to understand how to interpret anemias on a CBC. That's just one thing that I feel that nurses out there really don't understand the different types of anemias. And so I'm just going to go over the basic anemias, which is your iron deficiency anemia, your B12 and folate anemia, as well as, I'm just going to show you those three. All right, and I'll show you a few things in between. Okay, so we'll move on here. Okay, so what is anemia? It's a decrease in the oxygen carrying capability of the blood. So when you look at a CBC, usually the hemoglobin is less than 12. Sometimes it depends on your lab though. Sometimes it varies by 1 gram or so, depending on the, your laboratory. Men's values sometimes are different than females' values. Again, it depends on your laboratory. Usually you don't have symptoms though unless your hemoglobin is less than 10. Then you start having symptoms. Physical exam can give a few clues, but usually they may not have symptoms, especially if it's just a mild anemia other than having fatigue. Iron deficiency is the most common anemia in the world. So let's talk about red blood cell production, because that is where anemia stems from, is the red blood cells. So they're formed in the bone marrow. The RBC is matured. Remember, every 90 days they recycle. It's released into the circulation. Remember, oxygen, you do your pulse ox. That is what's carried on the part of the hemoglobin, which I'll show you. So it has a lifespan of 120 days. It's cleared by the spleen. And when you hear about reticulocytes, those are new RBCs in circulation. If you have no new production of these RBCs, so if you're anemic, your hemoglobin drops 1 gram per week. So that's pretty quick if you're having, and usually that would be more from a GI bleed. So you're losing blood for some reason. Okay, so this is normal hemoglobin. I'm not going to go through all this. You can read this of what hemoglobin really is. But if you look at this picture here, you can see the red blood cell in the vessel, and then break it down even further. There's hemoglobin molecules on the red blood cells. They contain several hundred of them. And then the hemi that's where the oxygen binds to that part of the hemoglobin molecule. So if your oxygen level's down, you could be losing red blood cells, you could be anemic, or you could be anemic for other reasons, but that's why shortness of breath is a real common side effect of anemia. I want to show you an example portion of a CBC. When you're looking at anemia, these are the things you look at to interpret it. It's not just the hemoglobin and hematocrit. You're looking at all of these that are listed. The hemoglobin, hematocrit, your MCV, MCH, and we can kind of skip the MCHC, but that's part of it, and then the RDW. So you have your red blood cell, which is made up of hemoglobin and hematocrit. A good tool is that your hemoglobin ratio to hematocrit is 1:3. So say your hemoglobin is 9, times it by 3, and your hematocrit is most likely around 27. So it's just an easy way to remember. So if a doctor puts you on the spot and you know the hemoglobin's 10, they're like, what's the hematocrit? Well, you just times it by 3, and it's most likely around 30. Your MCV is the size of your red blood cell, all right? And we use normocytosis, microcytosis, and macrocytosis. So the size. So obviously we want it to be normal. So that's the MCV, mean volume. Now the MCH is your color. So it's normochromic, hyperchromic, or hypochromic. And then let's go down to the RDW. That is your red blood cell distribution width. So think about a room, like a circle. And if you have normal red blood cell distribution width, all those hemoglobin molecules will just, be kind of crowded together, not too much. But if your red blood cell distribution width is far apart, so you only have 10 people in the party room versus 50, well, then your RDW number is going to go high because you have a higher width between people. So if you have 50 people and they're kind of more crowded together, your RDW is going to be normal or low because you have normal width between each. I'm just using people. But say you only have 10 people come into a party with maximum size of 250 that can be in the room, your width is going to be a lot farther if you spread the people out across the room. So look at it that way. If it's high, you're going to have more of a width between people in the room. These are all things that you're going to look for when you're looking at a CBC with these people in the inpatient or in the nursing homes. And I would really like you to go and look at their labs and kind of practice this a little bit to get an idea of how you'll feel so much smarter looking at these and be like, oh my gosh, I know what that is. All right, so we did talk about this already, but what this does, going back to this, the MCV, remember that is your size. This helps you to classify the type of anemia because you can't just treat all anemias the same way. It just depends where it's coming from and what it is. So you need to figure that out. So if it's microcytic, it's less than 80. Normocytic, 80 to 96, and macrocytic is greater than 96. And on a CBC, I don't expect you to know this for a test or anything, but when at a CBC, they'll always tell you what the normal values are. This can be an overwhelming chart, but just to give you an idea of all the different variations and the colors, distribution, that's the red blood cells can be. What we're going to focus on is the size variation, your normocytic, microcytic, and macrocytic. That's it. And we're going to focus on the color a little bit too. You guys probably have heard of sickle cell. I know you have heard of sickle cell, so this is what the sickle cell will look like. These are all different types of blood disorders. Don't have to know them. I don't even know all these. These are obviously just rare things, and if I saw something weird, I know a basic workup and even a little more extensive workup. If it was abnormal, I would refer to hematology. Okay, so let's talk about microcytosis. All right, microcytosis, what is that again? The MCV, right? MCV, let's go back right here. It's seen in iron deficiency anemia and thalassemias, which we're not going to talk about thalassemias. Iron deficiency anemia, you have a low MCV. It's microcytosis. All right, so you have normal red blood cells on the left on this picture here. All right, and then so you see how the volume of these are pretty hefty. Then you look over here and they're not. They're this is a microcytic anemia, so they're smaller. Oops. They're smaller than these over here. They're their color is a little bit pale here, but we're really looking at MCV, so we're looking at the volume. So the volume is decreased here. What are some causes of microcytic anemia, which would be an iron deficiency anemia? Well, maybe you're not taking enough iron in. Or you could have a chronic disease. So many of those people you'll see in the nursing home or even inpatient, they'll be iron deficient, not necessarily, but it could be an anemia of chronic disease, meaning that they're not losing blood actively, but their disease state is just causing a lack of hemoglobin and hematocrit to produce adequately, and so therefore it can cause anemia of a chronic disease. That's what it's called. So if you have kidney disease, that's really common, cancers and that kind of stuff. We're not going to talk about thalassemia or sideroblastic anemias. All of these are part of microcytic anemias. So your hemoglobin, hematocrit will be low and your MCV is going to be low. All right, so inadequate intake or uptake of iron, or anemia of chronic disease. When we say inadequate uptake of iron, you could be losing blood. When you think iron deficiency anemia, the first thing you want to do is exclude or rule out GI bleed. All right, so let's talk about the MCH. We talked about the MCV, the volume, and now we're going to talk about color. All right, so here's the mean cell hemoglobin here, and the MCH. That's the concentration, which we really don't pay attention too much. It's usually the MCH. So it's the color, chromic. So normal chromic, hypochromic, and again, your lab values, if you're looking at a CBC, will give that to you. Anybody that's iron deficiency, has a microcytic anemia, is going to be hypochromic. It's going to be pale. As you saw this picture here of iron deficiency anemia, look how much paler it is on the right versus the left. Put it on hold. Does anybody want 2 dogs? They're for sale. They are small and they're barkers. So anyways, okay, let's move on here. Here's another example of the hypochromic in iron deficiency anemia, and then versus normal chromic, where the color looks pretty good. You can see on the left it looks pretty pale there. Now let's talk about the RDW. That's the red blood cell distribution width. All right, so RBC size, normally all red blood cells are about equal in size. All right, so the RDW, the distribution width, is greater than 15% is abnormal. Remember I said it's higher, indicating that new cells are different sizes, smaller, larger as compared to older cells. And think of that room also. This is one of the earliest lab indicators of I would say iron deficiency anemia. I would change that to iron deficiency anemia. So when you're looking at a CBC, if you see that RDW elevated, I would suspect iron deficiency anemia or an anemia of chronic disease, but usually iron deficiency anemia. Because why are they different sizes? Why are there as many? Why is the distribution width so far apart? So you're losing blood. Why are you losing blood? It could be a chronic thing from the bone marrow, or again, you want to first rule out blood loss, active bleeding going on. But you'll feel pretty smart when you look at a CBC and see that RDW elevated, and you're like, that's probably an iron deficiency anemia issue there. You can have a normal hemoglobin and hematocrit, yet have a high RDW. Number one, either they are starting to have bleeding or iron deficiency anemia, or they've already had it and they're on iron supplements and therefore it's corrected. So you'd be like, well, it looks like you're responding to treatment well. What is the reticulocyte counts? Well, this is the body's normal response to anemia to attempt correction by increasing the number of reticulocytes. Remember, those are the new cells. So it's normal for you to have an abnormal normal response to anemia is reticulocytosis, basically. So if you have an abnormal level, that's common. So they develop and mature in the bone marrow. They circulate for 1 day before they become a mature RBCs. Normally about 1% of the RBCs are reticulocytes. So if you look at the picture, you have the reticulocytes have the little purplish in it versus the red blood cells that don't. So what I want you to focus on, remember we had the MCV. You have the MCV, MCH, and RDW. The MCV is your mean, the volume basically. It's either going to be microcytic, normalcytic, or macrocytic. And microcytic, we're going to focus on iron deficiency anemia, but just remember that you can have that anemia of chronic disease. Normalcytic, you can also have a low hemoglobin and hematocrit, but you're going to be normalcytic, meaning your MCV is normal. And then you're thinking, do they have an early iron deficiency anemia or do they have a chronic disease state? Because that can also be anemia of chronic disease, where all you see on the CBC, a guy has, let's just say a guy or female has chronic kidney disease and his hemoglobin and hematocrit's low, but everything else is normal as far as RDW, MCV, MCH, then you could suspect that he probably has anemia of chronic disease. It's just chronic for him. It has to do with the bone marrow issue. Now let's just say somebody is macrocytic, too much. Well, then you're going to think about megaloblastic anemias, which you guys need to learn about because they're really common. That's your folate and B12 deficiencies. When we think about alcoholism, we think about folate deficiencies and B12. Remember, folate's a B vitamin, so they're megaloblastic. It's going to look macrocytic when you're looking on the CBC because of the way the red blood cells look. So the most important thing to do first is determine the cause of the anemia, which I mentioned. Iron deficiency anemia, here's an example. If we're looking at a CBC, your hemoglobin hematocrit are going to be low. Your MCV is going to be microcytic, so the size will be small. The color is going to be pale, small and pale. And your distribution width is going to be high because you're not going to have as many. They're all different sizes and they're spread far apart. So what is the common causes? Women that get heavy periods. I do pre-op, so I see a lot of people coming in for DNCs and trying to figure out why they're having so much heavy bleeding, they're losing blood, and therefore they're iron deficient. So we put them on iron, have them go see gynecology, and they do a DNC, clean them out. Hopefully that will help it. A lot of times we're doing ablations now that will end up, if you're done having children, that will thin out the lining of the uterus permanently, and therefore you won't get a period anymore. GI bleed is the other most common reason. So ulcers, stomach cancer, because think about that. You can have some erosion, you're bleeding. Ulcerative colitis, intestinal cancer, hemorrhage. So these all are from the GI. Decreased iron intake. We don't see it too much in this country, but we see this a lot over in underdeveloped countries. Also, increased iron requirement are needed for children, pregnancy, and breastfeeding. The most common symptom is fatigue, shortness of breath, pale nail beds, pale skin. That's very common. When it becomes more severe, then they can start having some tachycardia, some chest pain. That's not good. When you think ischemia, so ischemia meaning heart attack, is related to anemia, or they can go hand in hand. So if somebody is elderly and they're losing blood, they have a very high risk of having a heart attack, because think about that. That's what oxygen is carried on. If you have a lack of oxygen on the hemoglobin because you're losing it, then you have an increased risk of heart attack, stroke, and that kind of thing. So it's very, very important to find out the cause first. Headache, dizziness, lightheadedness, cold hands, feet, inflammation, soreness of your tongue. It's usually, though, more with B12 deficiency, which we'll talk about. Now, this thing is common, actually, cravings. It's called pica, P-I-C-A. I had someone crave earthworms once, which I was like, okay. But anyways, I said, did you eat any earthworms? She said, no, but I crave earthworms. So, I do ask people if they have any cravings for ice. Are they chewing on ice? And that's really common. Poor appetite. That's usually with infants and children. But adults, you'll see more. They're really tired. They have the pale skin, and you look at their nail beds. You can compare your nail beds to theirs if you're not really sure what a pale nail bed looks like. And they just feel cold. They're losing iron. There's an example of pallor of the sclera, the hand pallor there, but usually the face will look pale in the nail beds. Remember, it's a manifestation of an underlying process. So if you see anybody with a microcytic anemia, you think that they're losing blood, and you need to figure out where it's coming from. Until it's ruled out, then you can say, well, maybe it's because of their chronic disease that they have going on. How are you going to treat this? You're going to give them iron. So many times if women come in or people come in and I think they have a GI bleed going on, let's say I'll do a quick stool for blood. I'll do a rectal exam and they have blood in it. I will send them right away for a diagnostic colonoscopy to GI, which usually will get them in within the next day or two, because they got to do the prep and stuff. And for women, in the meantime, I will put them on some iron, and I'll have them take 300, it's usually 325 milligrams, 3 times a day. Food decreases absorption, so they should take it on an empty stomach. And the vitamin C helps increase absorption, so orange juice is really good to take with that. You have them follow up in 3 to 4 weeks. The hemoglobin levels increased by 1 in 3 to 4 weeks. The treatment, continue it for 3 to 6 months. So I just want to talk about a little bit on this here. So let's just say the patient comes in and they had their colonoscopy, and they're anemic, but they found the bleed, and so they fixed it. Everything's all done. Or the woman comes in, she had a DNC, she's not bleeding anymore, but obviously there's still going to be anemic, because remember, the red blood cell takes up to 120 days to recirculate. So you want to put them on some iron. So you're going to have them follow up in 3 to 4 weeks. You're going to check the hemoglobin hematocrit. It should return to normal after a couple of months, because remember that recirculation. It may not return completely to normal after a couple months. I'd say 3 to 4 months, but you want to continue treatment for 3 to 6 months, because you're replacing the body's iron stores in the bone marrow. If you want to really check to see if it's working, the earliest, the best blood test to get to check to see if you're responding to treatment soon is a ferritin level, because those are replaced very quickly. So you can check in about 2 to 3 weeks, and if your ferritin level is going up, then you know they're responding to the iron treatment. You don't need to know that for testing purposes, but it's good to know for knowledge. You're going to see a lot of anemia being a nurse. So what if somebody has a hemoglobin less than 9? That's pretty dang low. So number one, unless it's sudden blood loss from a GI bleed and they show up in your ER, definitely could be like that too. But if it's a suddenly, you should suspect cancer, also like infectious disease or inflammatory issues. But malignancy is really huge, like these elderly people that all of a sudden their labs go out of whack. You're like, what's going on inside the body? But you got to rule out the GI bleed first. Okay, so now we're going to talk about, let's switch gears here. We were talking about microcytic anemias before, anemia, which would be your iron deficiency anemia or your anemia of chronic disease. Now let's go to folic acid deficiency. When you hear the word megaloblastic, think megaloblastic means like your macrocytic anemias. So that means your hemoglobin hematocrit are still going to be low, but your MCV is going to be large. So they're going to be large, macrocytic. The color is going to be usually a normal color, and that RDW that we talked about with iron deficiency anemia is going to be normal. So you're not going to see any abnormality with that. So if you see the key thing with folic acid and B12 deficiency is the MCV is going to be elevated. If you see that and the RDW is normal, you're like, I wonder if they have a B12 or folic acid deficiency. Your hemoglobin hematocrit are going to be low, but you got to go further and read the other portions of the CBC. Remember, folic acid it's a B complex vitamin. It's water soluble. It's found in vegetables, fruits, nuts. It's peed out in the urine. When people take B complex vitamins, their urine is bright yellow. It's from the B complex. Your body takes what it needs and then it pees out the rest. But folate deficiency, which is common in alcoholics, elderly alcoholics, remember though, alcoholics, folic acid deficiency, thiamine deficiency, all those B vitamins are very common because they're just not getting the nutrients at all. It causes this macrocytic normochromic anemia. Also, people with celiac disease are at risk for that, but just think alcoholism. Also, there's some medications, I know this picture's covering it, but Dilantin, which is your phenytoin, which I never can say that, sulfasalazine, which is used for rheumatologic disorders and Crohn's disease, and then this trimethoprim, that's your Bactrim antibiotic. If you're taking an antibiotic for 7 days in a healthy person, it's not really something to worry about because you're usually not taking it long term. Folic acid deficiency, one of the common signs is premature gray hair because it maintains that methionine level in your body. It's amino acid, and it's one of the building blocks for healthy hair. So if you get premature gray hair, you may want to think about that. And then you take a folic acid supplement because that will help. What are some signs and symptoms? Well, it's anemia. So again, you're going to have that fatigue. You may have a poor appetite, headache, pale skin, gray hair. So one of the things, though, that's hallmark to this one is the gray hair. So just remember that. And you're going to treat this by replacing it. So usually it's 1 gram or 1,000 micrograms a day of supplemental folic acid until the levels are replenished. So how are you going to do that? You're going to get a folic acid level. So let's just say you saw that CBC and you're like, I wonder if they have a B12 deficiency or possibly a folic acid, because you're seeing that macrocytosis, the megaloblastic. So you're going to, the doctor should get, or provider, NP, right, should get a folic acid level and a B12 level to find out what is going on. Where is this deficiency coming from? Usually it's corrected in 2 months, but diet is really huge with this, and make sure that you're telling them to eat these things. The other megaloblastic anemia or macrocytic is a B12 deficiency. So again, your hemoglobin and hematocrit are going to be low. Your MCV is going to be macrocytic. Your MCV is going to be hyper in color or normal, and your RDW is normal, but you're really paying attention again to this macrocytic thing with the normal RDW. B12 is found in a lot of foods of animal origin. It's really essential to the development of your red blood cells, and it's essential to your nervous system. There's pernicious anemia, and then there's just a lack of B12, and there's 2 different ways to treat it. We'll talk about that. Because pernicious anemia means that you don't have an intrinsic factor. It's a protein in the stomach. So if you don't have that intrinsic factor, then you really need to have some IM injections of B12 because you can't absorb the B12 very well through your GI system. There's other reasons why you can have B12 deficiency, such as sometimes surgery, canned medicines, diet. There's the lack of intrinsic factor, but some people just have anemia and we can't really figure out why, but we have them take oral supplements if they still have that intrinsic asthma. One thing with B12 deficiency, you have to be really careful and catch it right away. In the elderly, sometimes it's very hard to catch, and so they will end up becoming confused before you figure out that that's possibly what's going on. Although confusion can be also a sign of, UTIs and stuff in the elderly, but B12 deficiency is another one that can cause confusion. The one hallmark sign of B12 deficiency is stocking glove neuropathy, so they can get like tingling of their hands and their feet, but their hands, it's really a common and hallmark to the B12 deficiency. So what you're going to see again is the macrocytosis. If they're taking B12, you want to monitor their potassium. It's just one of those things that the potassium can become abnormal and go down. All right, so for some reason this one didn't work out, but I want you to remember, so you have the red beefy tongue that can happen with that, confusion, and remember the tingling hands and feet, which is called the stocking glove neuropathy. So here's the difference between the pernicious anemia and B12 deficiency versus folate. So the pernicious anemia, you're going to get a CBC, a peripheral smear. You guys do not need to know this. One thing I want you to know about this pernicious anemia and B12 is you're going to have a low hemoglobin and hematocrit, okay? then you're going to know that they should be checked, and then they're going to have macrocytosis. So that MCV will be high, but their RDW is going to be normal. If that MCV is high, you're thinking it's either B12 or folate. Then the doctor should be getting a B12 and folate level. A Schilling test is something to determine if you have that intrinsic factor or not. So are you able to digest the B12 vitamins in their GI tract or not? Because that protein is hallmark or what you need to digest that B12. That's usually done in an outpatient setting, but just so you know, that's the difference. How are you going to treat it? You're going to, if the Schilling test is positive, you lack that intrinsic factor. Sometimes you can bring it up by taking larger amounts of B12 orally, but usually we give injections. If you just have a B12 deficiency and you still have that intrinsic factor, you just take some oral B12 and that would be sufficient, as well as dietary. If you have a folate deficiency, again, once the CBC is done, you're going to check a serum folate level. There's others, this methylamonic acid, that can help determine if it's the folate and homocysteine. You don't need to worry about that. Both will be elevated in B12 deficiency, but only the homocysteine will be elevated in folate deficiency. You don't need to know that. That's just stuff beyond in a workup of that. I really want you to focus on reading the CBCs and understanding how to differentiate it and then how we would treat it. This is the treatment for pernicious anemia. Remember, lacking that intrinsic factor in the B12, just a plain old B12 deficiency. So the pernicious anemia, you're going to do IM or sub-Q daily for a week and then weekly for a month. Now, who really wants to do an IM injection every day for a week? I certainly wouldn't, but anyways, that's just what's recommended in one particular guideline. Sometimes we'll just give it once a month. Just the main takeaway is that they'll probably need IM injections. This requires maintenance, so it's lifelong administration of monthly B12 injections. Usually recommended iron the first month of treatment. So sometimes they recommend that you take an iron supplement the first month of treatment. You follow up in 2 weeks and you're going to check their, I wouldn't say hematocrit, I would say you're checking their CBC, which would be your hemoglobin, hematocrit, MCV, etc. They really need to have an endoscopy every 5 years. Your B12 deficiency, send to a nutritionist because they really need to look into what are they not eating. If they're vegan, again, send to a nutritionist. And then they can also, a lot of times if you just have a really low B12 because you're symptomatic, I will give some injections to boost them up, and we usually have them in the office. And then you have them also be on daily oral supplementation. You'd have them follow up. I'm going to do a couple exercises with you. Usually these are normal lab values, but on these, oh my gosh, hold on a second. I got to go back to this here because this didn't work out. I want to move this down. Okay, hopefully maybe this will work. Okay, let's go from the current slide here. Okay, so this is case study number 1. So let's think about what this could be. Here's the normal lab values are on the right. So she's a 65-year-old woman with rheumatoid arthritis, and you find the following results on a hemogram. So her hemoglobin's 10.5. Is that lower? Is that low or is that normal? So looking on there, it's low. Hematocrit's 33. Remember, times it by 3. So it's around 1:3 ratio. So we know both of those are low here. Then we're looking at the MCV. Let's see, it's 88. Looks like that's normal. It's normal. And then the RDW is normal. So let's think about this. So this MCV is not microcytic. If it was microcytic, it would be lower than 80. That would say iron deficient. The RDW, if it was high, you'd think iron deficient. So, okay, it's not that. But she is, and this MCV is not elevated to say, okay, she has a B12 or folate deficiency. So really she's just showing this. Most likely, she has rheumatoid arthritis, so it's probably anemia of chronic disease. So it's something that she's had. You'd probably want to look back at some past CBCs to see if that is chronic for her, and look into that further. Will they be on iron? They might be on iron if they have anemia of chronic disease, but a lot of times if it's like a 10, 11, or 12, they may, or just below normal, they may not be on anything. So the second one is a 47-year-old something woman. That's okay. Your hemoglobin's 10, so that's low. Hematocrit's 35, that's low. Now your MCV is less than 70, so that's low. So right away, microcytic. RDW, that's high. So the RDW is high, the MCV is low. So you're thinking, what? Iron deficiency anemia, okay? Iron deficiency anemia, why are they having that? What's the cause? You've got to find out the cause. It could be a GI bleed. Could be just iron deficient from diet, but it could be a bleed somewhere. And here's another one. You have this man, which I know this didn't work out here. He's a 47-year-old. He has an hemoglobin of 9, hematocrit of 27. The MCV is 108. Most likely the RDW is normal. So he's low, low, high. So that's more of a macrocytic or megaloblastic. So based on this, I'd think, oh, is he B12 deficient? Folate deficient? Maybe talk to him about symptoms. They probably have to go further with some labs to find out what's going on with that. So I hope that helped, and that's it.